Hello, I'm Dr. William White from the University of Connecticut School of Medicine in the United States. I'd like to discuss the effects of Vibegron on ambulatory blood pressure in patients with overactive bladder, results from a double-blind study. These are the disclosures of the co-authors and co-presenters today. The study was funded by Urovant Sciences. Pharmacological treatment for overactive bladder includes anticholinergics and beta-3 adrenergic receptor agonists. Beta-3 adrenergic receptor agonists may have adverse effects on blood pressure and heart rate due to beta-adrenergic receptor expression on cardiac tissue. Ambulatory blood pressure monitoring is a sensitive method used to determine whether clinically relevant changes in blood pressure and heart rate are induced by new drugs. The objective of this study was to characterize the blood pressure and heart rate profile of the novel beta-3 adrenergic receptor agonist Vibegron using ambulatory blood pressure monitoring in patients with overactive bladder. There are three different types of blood pressure measurement used in both clinical practice and in clinical trials. The in-clinic method, which is, of course, most patients and physicians are familiar with, is typically a single or double reading in a medical care environment, and it's fine for clinical practice. But there are some problems with it when it comes to clinical trials. There's a lot of variability between measurements, and then we cannot remove the white coat effect or the mass hypertension effect that's seen with this methodology. Home blood pressure monitoring is a method that is used by patients to improve their engagement in their care. It's relatively inexpensive, but there is a lot of inter-device variability, and it's not associated with nearly the outcome data that's seen with in-clinic measurements or ambulatory blood pressure monitoring. We like to use ambulatory blood pressure monitoring in clinical trials to assess antihypertensive drugs as well as off-target effects of non-cardiac drugs, because we can get frequent measurements, including during sleep, and there's a great deal of data that allows us to look at the effects of treatments. For clinical practice, it's somewhat high cost and inconvenient, but in clinical trials, it's become the gold standard. So this particular study was a standalone randomized controlled trial. And as you can see to the upper left-hand panel, in adults with overactive bladder between the ages of 40 and 75 years, patients were randomized 1-to-1 to Vibegron at 75 milligrams daily or placebo after having a baseline 24-hour blood pressure assessment. After 28 days of therapy, they underwent 24-hour ambulatory blood pressure assessment again. The primary endpoint of this study was the change from baseline to day 28 in the mean daytime ambulatory systolic blood pressure. Key secondary endpoints included the change from baseline to day 28 in mean daytime ambulatory diastolic pressure, heart rate, and the mean 24-hour changes in these parameters. From a safety perspective, all adverse events were recorded and vital signs were measured. In the trial, 455 patients were screened. Of those, 108 were randomized to placebo and 106 to Vibegron. In both treatment arms, 97% of the patients completed the study. These are the baseline clinical characteristics of the patient populations who were randomized. The mean age of the patients were about 59 years. About 67% were over the age of 55, and about 75% were women. Pre-existing hypertension was present in about 35% of the population. The mean blood pressure in the clinics averaged about 121 over 76 millimeters of mercury. The mean heart rate about 71 beats per minute. This is the primary and secondary endpoints. The mean daytime blood pressure changed by 0 in the placebo group and 0.8 millimeters of mercury in the Vibegron group for delta of 0.8, which was not statistically significant. Likewise, the diastolic blood pressure changed by 0.5 millimeters of mercury versus 0.6 for a net difference of about 0. Heart rate changed minimally as well by 0.9 beats per minute compared to placebo. For the 24-hour averages, the changes were also very small, about 0.5 millimeter of mercury for the systolic, less than 0 for the diastolic blood pressure, and only 1 beat per minute for the heart rate. These figures demonstrate the 24-hour blood pressure curves over the hours of recording from 8 o'clock in the morning till the next day at 8 o'clock. The blood pressure that is lower in these right-hand portions of the panels is during the sleep period for patients. Blood pressure goes down about 15 to 20% during sleep in most individuals. You'll note that for systolic blood pressure in the upper panels, diastolic blood pressures in the lower, that there's really very little to no difference between placebo and Vibegron on ambulatory blood pressure measured hour to hour. Adverse events were infrequent in this study, only 1 serious adverse event of placebo and 1 in the Vibegron group. There were no deaths. For those adverse events that occurred in greater than 2% of patients, hypertension stood out in 3.7% of the placebo patients and 4.7% on Vibegron. However, 1 of these patients took a prohibited medicine, benteramine, known to significantly increase blood pressure. Otherwise, all of the adverse events were infrequent and of a non-serious nature for both placebo and Vibegron treated patients. So in conclusion, in patients with overactive bladder, once daily treatment with the novel beta-3 adrenergic receptor agonist Vibegron was not associated with a statistically significant or clinically meaningful effect on blood pressure or heart rate. Treatment with Vibegron was safe and well tolerated. Thanks very much.